This is an overview of Part 1, What is Health from the Western Perspective. We'll be looking today at the biomedical and biopsychosocial models of health. If you ask 10 people to define health, you will get 10 different answers. Ask this guy, kind of vain, me, that's all I can say. This one, I think health would be maybe like having a body. Getting rid of this cough, that would be health. Eyes that can blink. Rockin' and rollin', that would be health to this old guy. Only a sprain, no broken bones. That's health here. No more stiff elbow. Ouch, that's health for him. Pregnancy test negative. I guess that feels healthy to this couple. You can see that in most of these cases, the idea of health is varying depending on the situation, and they're kind of a joke, but we do have a lot of varying definitions of health, and the variance comes into what we are wanting, needing, lacking at a given point in time. So if you're sick with a very difficult illness, if you're sick with COVID, maybe good health would be represented in breathing, just being able to take a deep breath. And if you have a broken bone, good health might be defined as healing that bone. So that starts us on our topic for this week. Each definition of health may vary in the importance of health practices. So maybe avoiding environmental hazards is a practice that's a part of health. You wouldn't swim in polluted lakes, you wouldn't buy a home near the interstate, and so forth. Maybe avoiding harmful substances or practices is the practice that brings health, like smoking, fad diets, alcohol, excessive screen time, so taking care in that way. Maintaining health practices. So if you have good practices, keeping them going, eating appropriately, sleeping regularly, and so forth. Maybe engaging in preventive health care with dental and physical exams, eye exams, pap tests, breast exams, and so forth. Practicing safety, like repairing your car regularly, taking first aid and plenty of water when hiking, wearing bell helmet, liking doors, and so forth. In the USA, we have two general models for Western health practices. We have the biomedical model, which focuses on the biological aspects of disease and illness, getting sick, going into the hospital, and getting cured. And more recently, we have a morphing into the biopsychosocial model, which focuses on a range of biological, physical, psychological, and social conditions that contribute to disease. We'll take a look at both of these more closely. So in the biomedical model, which is the basis of Western medicine, it comes in steps. First of all, you're exposed to a pathogen. You're just living normal with or without healthy habits, and you encounter someone with COVID-19, say. Later, we have the biological onset of disease, so you didn't fight off the pathogen. So the disease is now in your body, but you don't know it yet. It's just beginning to form and mutate. This is the preclinical phase. So you're not symptomatic. You may not know you've been exposed, but the disease has begun multiplying in your body. Symptoms appear at this juncture, and then you come into the clinical phase, where you go to the doctor. After a bit of time, you're diagnosed, a treatment of some sort is begun, and if the outcomes, maybe you're cured, or maybe you learn to live with the disease, or maybe deteriorated, or something like that. And so then the diagnosis comes again, therapy begun, another treatment, and so you might go back and forth around here for a time when you have this disease. So you can see that there's no addressing any health issue until that point when you're fairly sick. And that's one component of this biomedical model. An example of treatment in the biomedical model might be you go to, your symptoms appear, you're having low back pain. You don't know what's causing it. And so then you would get a diagnosis. You're already in pain, so you're going to have a diagnosis looking at the low back by X-ray, MRI, physical examination. Maybe you'll be treated. Maybe you'll have surgery. Maybe you'll have medication. But what's missing from this model? The fact that what's missing from this model is what we'll be considering in the next paradigm. So to summarize, in the biomedical model, the focus is on disease. It's reductionistic because disease is defined by some sort of a biological defect. So there's a linear relationship between some defect and this condition that you have. It's exclusionary because problems that aren't explained by this biological defect are excluded. They don't consider anything outside this direct linear relationship. Mind-body dualism, in that the physical body is treated separately from the mind, and so any relationship between any psychological aspects in the body are not considered. And it's primarily biological assays and biological interventions in order to assess and treat the condition. Now, there were some benefits to it. The germ theory of disease is a little video clip I'll show you, but it's just the discovery of germs causing disease. And once we had that understanding, well, there's accuracy in that model. Then we could use sanitation. Then we discovered antibiotics to fight off infection. We had declines in infectious disease at that point and an increased life expectancy. And so reducing it in this way to germs, that is, reducing the causes of disease to identifying germs, allowed us to identify and treat the underlying biological defects. For example, once we understood that insulin was not able to do its work in type 1 diabetes, we could supplement insulin. So it was helpful. And we can see that it's successful because when this biomedical model came into place, we had significant increases in life expectancy from the time of 1900 when we did not have an understanding of these practices. Another example, before the discovery of insulin, we had much shorter life expectancy for a child with type 1 diabetes. And you could see that as we understood insulin and learned how to help people with it, we have a much longer life expectancy that emerges in our time. So we can see the benefits of this biomedical model. But can we also see some problems? Can we do better? So we do have some problems, and first we have conceptual problems. So conceptually, it limits the idea of disease to a specific derangement of a physical mechanism. We have mechanical issues. The body is viewed as a machine with separate components. We have a one-dimensional framework. We don't consider the broader causes of a condition or a pathology. All we're considering is a linear relationship, one cause, one effect, very often. It's dualistic. Mental and physical health are considered separately. And it's medication-based. Problems not viewed as correctable with physical intervention, like medication or surgery. If it can't be treated with one of those two things, then it's abandoned. There's not many alternatives to that can be offered in the standard biomedical model. There are personal problems with the biomedical model. For example, it's doctor-based. There's a little halo put around this doctor's head, and he's viewed as a godlike figure who knows all, when in fact he's just a trained practitioner. People would tend to place their health in the doctor's hands and obey without question when this isn't always wise, because medical knowledge, like all knowledge, is always evolving. And this isn't any disrespect to doctors. They're remarkable, amazing people, and we're very grateful for them. But the problem with this model is it leaves out the personal responsibility. So if you have a condition and you go see a doctor and the doctor treats that condition with medication or surgery, you're not taking any responsibility for the factors in your life that might contribute to this very condition. So you might feel your own health is out of control. It's in the doctor's hands, this godlike figure, and then you don't make the necessary changes that would lead to improvement in the problems that arise. Secondly, it overrides what we know about our own bodies. And we are our own best informants of our own bodies, if we know how to listen to it. But if we absolve responsibility for our own bodies and place that responsibility instead in the hands of the all-knowing doctor, then we get even further out of touch with our bodies and fail to listen to the clues that it may be giving us. Another problem with the biomedical model is that it prioritizes disease over health. So if priority is given to disease and treatment of disease rather than to proactive maintenance of good health, we end up creating conditions in our own lives that could contribute to good health. So people who go to the doctor with physical complaints are given greater value than those who have psychological complaints because those two are separated. The resources of our medical system, instead of being devoted to preventive care and creation and maintenance of good health, it's devoted to biological tests and interventions. Greater access provided to those with diseases. People with disease will get forwarded to the front of the line for medical care, whereas wellness treatments are put in reverse, and prevention becomes a lower priority than treatment. And it leads to different spending problems. So we can see this model here that we have spending levels increasing dramatically for this black line representing prescription drugs. We have the green line increasing a little bit for the doctors who prescribe those drugs, and very little to psychologists, counselors, social workers, who may be the ones to persuade people to create and maintain good health, and yet very limited resources to those individuals. So we see very much a reactionary effort to treat disease with medications in an industry that makes a profit off of the delivery of those medications. So that requires a paradigm shift, and the shift that we make is to what we call the biopsychosocial model. And you can see why. It considers biological frameworks, sociological frameworks, and psychological contributors to health. So biologically, indeed, age, gender, genetics can all contribute to the onset of a desirable or undesirable condition. We all have unique physiological reactions, a tendency to have, say, heart rate to elevate quickly or more slowly. And we have differences in our tissue health. So our organs have varying levels of health and so forth. Sociological differences. So interpersonal relationships can indeed contribute to health. Good health with good role models, or poor health if people are bringing you into bad habits, or if people are creating stress in an individual's life through abusive relationships or unhappy relationships. We know that social support makes a big difference in recovery and good health overall, and we should consider that. The absence or presence of social support when we're treating people. And socioeconomics. What is the economic status that allows someone to, say, have time to maintain good health practices, have time to tend to their own bodies? Finally, psychological factors also play a role. Mental health. A person who, for example, is suffering from depression is not likely to pay much attention to their own health and well-being, exercise, sleep, and healthy diet. Emotional health plays a role in this, and beliefs and expectations. If an individual feels that their own health is out of their control, they're less likely to proactively seek good health practices. So the biopsychosocial model takes into account all of these when treating patients. So the back problem we looked at earlier, what might be going on here? So we can treat this back problem, but what might be causing the back problem? There could be biological issues. It could be related to age or gender. Maybe the bones are getting weak. It could be related to sociological conditions. An overworked person who is doing too much lifting, or even if this person is just doing too much work around the home, or other things like that that don't allow her to properly exercise. And psychologically, perhaps this person is carrying tension in her body in some way that prevents her from getting the proper exercise, or doesn't have the stability at this time to get the proper exercise. So if we compare these two models, we find that the biomedical model focuses on biological factors, whereas the biopsychosocial model focuses on biological, like a virus, but also psychological and social factors. In the biomedical model, the responsibility for illness rests on an external force, like a virus, something that's out of the individual's control, whereas in the biopsychosocial model, the individuals are responsible for their own health. Treatment in the biomedical model would be strictly related to the physical state of the body, like we would treat a physical condition with medication, surgery, something like that. Whereas in the biopsychosocial model, we'd address the whole person, including things like behavior, beliefs that are in error, coping, compliance, social support. The responsibility for treatment in the biomedical model is with the medical profession, not with the individual, but in the biopsychosocial model, the individual has the responsibility for the treatment, gives us back our own bodies. And finally, the mind-body relationship is discrete in the biomedical model, meaning they're treated separate, and either you have a problem in your mind or a problem in your body. But these are reciprocal in the biopsychosocial model. Your mind impacts your body impacts your mind, and this is taken into consideration. There are pros and cons even to this model that sounds so beneficial and helpful. The benefits include individualized healthcare services. The patients are more satisfied, they have more time with a provider, and so they're more likely to comply with treatment regimens. This leads to a reduction in repeat visits. Individuals take self-agency, so we're more likely to have long-term better outcomes, and we have fewer unneeded prescriptions. And finally, we have improvements to mental health treatment. But there are some detriments. It takes more time and costs more money. It requires more detailed assessment because now instead of just assessing the body, we're assessing many dimensions of the person. It is a complex model, considering so many dimensions, and therefore there's a bit of subjectivity, meaning we're not maybe going to get the same results from each assessor. It tends to be a luxury for affluent people, which is often the case of best practices, and not available to people who might well need it more, who are less affluent. At this time, medical personnel, people who go through medical school, are not well trained in social or necessarily psychological aspects of good health. And finally, there's not at this time straightforward guidelines for treatment in this model, so it really rests on individuals to determine what the best way is to implement it. So in summary, we examined the biomedical and biopsychosocial models of health. The biomedical model focuses on the physical, while the biopsychosocial takes on a holistic view, but both have sound contributions and challenges to overall public health.